Okay, so good morning, good afternoon, and good evening all. A very warm welcome on behalf of the IAPB events team. We're very much looking forward to supporting you with today's Focus on Glaucoma webinar. We addressing inequity in access to glaucoma services in North America. We're handing over to Suzanne Gilbert, the Senior Director for Research of the SEVA Foundation.
Thank you very much, and welcome everyone. We're delighted you can be part of our World Glaucoma Week celebration of the International Agency for the Prevention of Blindness, and with co-sponsorship from Allergan. I'm delighted that we're able to draw this spotlight to glaucoma, the fourth leading cause of blindness in the world. We have a range of activities happening in every region of the world, webinars, lectures, chats of various kinds and special articles to just bring a focus to glaucoma this week of all weeks of the year. Today, our 1-hour program will open with a keynote talk, and it will be followed by an interactive panel of experts from the US and Canada from the worlds of optometry, ophthalmology, and patients' rights. Participants, you all joining from around the region, are welcome to provide questions using the Q&A button. And we really look forward to stimulating conversation together at the close of our keynote. Speaking of our keynote, we're very delighted to introduce Dr. Leon Walker Herndon. Leon is professor of ophthalmology and chief of glaucoma at Duke University Medical Center in Durham, North Carolina. In addition to his extensive research and teaching in glaucoma in the US and Ghana, Dr. Herndon is a leader in the American Academy of Ophthalmology, as well as the American Glaucoma Society, of which he is secretary currently, and in the next few years will become president. I am particularly pleased to note that Dr. Herndon has shared his leadership and mentoring with 74 clinical fellows in glaucoma. I'm always there for education. Therefore, on behalf of the group, I now invite Dr. Herndon to give his keynote, Inequity in Glaucoma Services, Costs, Sight. Thank you very much.
Thank you so much, Suzanne, for the warm introduction, and it's my honor to be able to share some spotlight on this topic during World Glaucoma Week. Next slide. I had the distinct honor early in my career to host the late Congressman John Lewis as he received an honorary degree from Duke. As he was co-sponsor for the glaucoma screening bill, our department had the opportunity to recognize his efforts. Congressman Lewis was very gracious with his time, and it was an honor of a lifetime to be able to spend some time with this civil rights icon. Next slide. So let's start about talking definitions. And we'll come back to these words throughout the talk. Disparity is simply a great difference. Equality is the state of being equal, especially in status, rights, and opportunities. Equity is the quality of being fair and impartial. Next slide. I borrowed this slide from Lisa Cooper. She's a great health services researcher at Johns Hopkins, where the cartoon illustrates the fact that some groups may need a boost to achieve health equity, to level the playing field, if you will. Next slide. In this 2017 Lancet article, Bailey et al. Used a contemporary and historical perspective to discuss research and interventions that grapple with the implications of what is known as structural racism on health inequities. Next slide. Structural racism refers to the totality of ways in which societies foster racial discrimination through mutually reinforcing systems of housing, education, employment, earnings, benefits, credit, media, healthcare, and criminal justice. Next slide. They looked at several measures of social and health inequities in the United States, and I will highlight just a few. Next slide. When it comes to median household assets, non-Hispanic white families have a median household asset of 110,000 compared to 7,600 for a Hispanic family and about 6,300 for a Black family. Next slide. When it comes to life expectancy at birth, white individuals have a life expectancy of about 79 years compared to 82 years for Hispanic individuals and just 76 years for Blacks. Next slide. Mortality related to heart disease, age-adjusted mortality per 100,000 population, 166 among whites versus 116 among Hispanics, and 206 among African Americans. Next slide. In this New York Times opinion piece, Gus Wozurek points out that in 2018, Black people died at a higher age-adjusted rate than white people for 9 of the top 15 causes of death, and that if Black people had died at the same age-adjusted rate as white people in 2018, they would have avoided 65,000 premature excess deaths. Next slide. Next slide. Next slide. Vital statistics show that for just the first half of 2020, the life expectancy has dropped for all groups compared to the previous year. Next slide. And this does not really reflect the full burden of the COVID pandemic. The life expectancy for Black males, as you see, has dropped 3 years compared to just the previous year. And I obviously have significant personal concern about these findings. Next slide. And I quote Anthony Fauci, when you're in the middle of a crisis like we are now with the coronavirus, it really does ultimately shine a very bright light on some of the real weaknesses and foibles in our society. Next slide. We find that over the past year, there have been several publications that demonstrate the pandemic, the dual pandemics that we're dealing with COVID and racial injustice. At least Mike and Dan LaRoche in this last article published in Clinical Ophthalmology in 2020 point out that COVID pandemic is stoking a fire that has long been burning, that those who are already at greatest risk for vision loss are even in graver danger. Next slide. The editors of the New England Journal of Medicine featured themselves recently in an editorial criticizing the response of the previous administration to the coronavirus pandemic. Next slide. And I quote, "Let's be clear about the costs of not taking even simple measures. An outbreak that has disproportionately affected communities of color has exacerbated the tensions associated with inequality." Next slide. Several organizations and companies quickly made statements denouncing racism this past spring, such as this statement from the American Academy of Ophthalmology, where they committed themselves to building a stronger society of fairness, justice, and opportunity for all. Next slide. We can click through that. It's been really amazing for me to witness the progress towards a more equitable society over the past several months. And I've been in part of countless Zoom calls, next slide, where we have had tough discussions in our reckoning with structural racism. Next slide. During the COVID shutdown, I was able to catch up on reading, where I educated myself further on the root causes of structural racism. I can highly recommend each of these books to you. Next slide. The American Glaucoma Society mission statement is that we are glaucoma clinicians, surgeons, and scientists dedicated to improving the lives of people with glaucoma by advancing knowledge and care through education, research, advocacy, and leadership. The AGS response has been to host social justice webinars. We've had 2 webinars. And some of the topics that have been covered include racism in society, medicine, and ophthalmology, recognizing and combating implicit biases, Each webinar has had over 100 attendees, including residents, fellows, and AGS members. Next slide. Lou, Friedman, and Collins addressed racial and ethnic disparities in vision care research recently. Next slide. And in their last paragraph of the paper, they state that to tackle the elevated burden of eye diseases facing marginalized communities, we need to promise and fulfill our commitment to increase racial and ethnic inclusion in clinical trials. Without addressing this important issue, we risk perpetuating rather than resolving current health disparities. Progress from investigators and institutions alike will help to alleviate the burden many underserved populations face in ophthalmology and vision care. Next slide. In 2012, Dave Friedman's group pointed out data to assess and trends in vision health disparities in the US were not being collected in a systematic fashion. Next slide. This is a graphic demonstration with availability and quality of existing data to evaluate and monitor disparities in vision health, where the darker boxes represent subgroups at an increased risk with a higher level of evidence. The white boxes indicate that limited data exists to evaluate disparity. The authors point out that the national campaign, Healthy People 2020, called for the elimination of health disparities that occur by race and ethnicity, gender, socioeconomics, geographic location, disability status, or sexual orientation. Well, we are now on to Healthy People 2030. Next slide. Zarelli et al. Published a paper in 2016 examining the diversity of ophthalmologists in the workplace in the United States. Next slide. So I want to spend some time with these figures because this shows you the proportions of ophthalmologists in the workplace over a 10-year period of time in the United States. And what you can see is that the trend is that there are more female, there's more female representation represented by the orange circles, but underrepresented minority representation remains much less than 10%. Next slide. If you look at the proportions of ophthalmology residents in the United States over this 10-year period of time, we see great representation, increasing representation among females, as you see with the orange line. And also Asians have had much representation through the residency program. But again, underrepresented minorities remain under 10% of the residents throughout ophthalmology programs. Next slide. And if we look at the faculty members, the proportion of faculty members in ophthalmology programs over the past 10 years, we do see a small uptick among women the past 10 years. But again, underrepresented minorities still make up much less than 10% of the ophthalmology faculty members in the United States. Next slide. Next slide. So if we look at the 2014 US Census estimate, we see that whites made up 62% of the population in 2014, compared to 4.9% among Asians, 12% among Blacks, and Hispanics made up about 18% of the population in 2014. Next slide. If we look at all ophthalmology faculty in 2015, we find that Blacks made up only 2% of ophthalmology faculty throughout the United States, compared to 3.4% among Hispanics. Next slide. If you look at ophthalmology residents in 2014, we see that Blacks make up only 2% of the ophthalmology residents throughout all the programs in the United States, compared to 32%. The Asians make up 32% of the residents, and Hispanics only 5% of the residents. And finally, if you look at all practicing ophthalmologists, they're about, Blacks make up about 2.5% of practicing ophthalmologists now in the United States. Next slide. I'd like to highlight this work by Angela Elam and her group in Michigan, where they looked at the disparities in receipt of glaucoma care between enrollees in Medicaid and those with commercial health insurances. Next slide. So the purpose of the study was to assess the utilization of diagnostic testing in patients with newly diagnosed glaucoma within 15 months of initial diagnosis. And there was compared utilization by insurance type, Medicaid being a federal and state program that helps with healthcare costs for some people with limited income and resources, and commercial insurance. Next slide. Data sources included Medicaid analytic extract and cliniformatics, and the inclusion criteria involved newly diagnosed open-angle glaucoma between 2007 and 2009 with no diagnosis in the prior 2 years. Next slide. Glaucoma testing within 15 months of initial diagnosis included visual field, fundus photography, and other ocular imaging or ocular coherence tomography, OCT testing. And logistic regression modeling was carried out. Next slide. So relative to Optum, Medicaid enrollees with newly diagnosed open-angle glaucoma are younger, next slide, more female, and more racially diverse than the Optum enrollees. Next slide. For each test, you can see that Medicaid patients receive significantly less testing across the board. Rates of fundus photography were low in both populations, but Medicaid patients still fare worse. The last set of bars represent patients who receive no testing. In Medicaid, almost 50% of patients diagnosed with open-angle glaucoma underwent no testing at all, compared to about 20% in Optum. Next slide. When looking at odds ratios, with Optum patients being the reference group at 1, again, you can see that overall Medicaid patients receive significantly less testing. For example, compared to Optum patients, Medicaid patients had 68% decreased odds of receiving a visual field. Next slide. When stratified by race, you can see that the disparity in testing is greatest in Blacks and Medicaid compared to Optum. For example, Blacks in Medicaid have 75% decreased odds of receiving visual field testing than Blacks in Optum. And the findings for fundus photography were only statistically significant for Blacks. Next slide. Here they compare the odds of having no tests. Overall, Medicaid patients had 244% increased odds of having no glaucoma testing despite being diagnosed with glaucoma. When stratified by race, that number jumps to 313% among Blacks. So what's driving these disparities? Determining causal effect of disparities in health and healthcare is usually a multi-level process. One must consider potential patient, provider, and systems-driven etiologies. In the study, we see that Medicaid patients receive less glaucoma testing of all types than those with commercial health insurance. Disparities are present in all races studied, but most dramatically among Blacks. And health policymakers and eye care providers should explore possible etiologies for these disparities and identify solutions. Next slide. Next slide. Now, a word from our sponsor. It's interesting to me that every time I order an OCT test in patients from the Heidelberg system, if you look at the very fine print at the bottom of the page, it reads reference database European descent 2009. Warning, classification results are valid for Caucasian eyes only. Next slide. I'd like to spend some time talking about this paper, the association between medication adherence and visual field progression in the collaborative initial glaucoma treatment study. Next slide. So there are 306 patients from the medication arm of the SIGIS trial who had at least one follow-up visit, and telephone interviews were conducted at 6-month intervals. Participants were classified as non-adherent if they reported missing one or more doses. And adherence to medication was assessed at each follow-up visit and summed over all follow-up visits. Next slide. So compared to patients who missed no doses, patients who missed more than 2/3 of their doses were 10 years younger. They had a greater visual field loss at baseline. They're more likely to be African-American, 67% versus 33%. And they had a high school education or less more often. Next slide. So this is where the rubber meets the road. This is the first, one of the best studies that's shown that poor adherence leads to worse outcome. An increase in the number of visits where a patient reported a missed dose was associated with a decrease in mean defect, or the visual field is getting worse per visit. And predicted loss of a mean defect over 8 years for patients who were never missed a dose was 0.62 decibel, all the way down to if you missed more than 2/3 of your doses, that was associated with much greater loss of visual field. So showing poor adherence has shown deleterious effect on one's glaucoma. Next slide. I wondered about follow-up. So one thing is adherence, taking medications. How about keeping your appointments? This paper was a prospective recruitment of 152 glaucoma patients at San Francisco General Hospital, with one-to-one matching of cases. Cases were those patients who showed inconsistent follow-up with their visits versus controls, those who kept their appointments. The data were collected via oral questionnaires. They found that Black and Latino patients were found on average to show less consistent follow-up relative to whites. The proportion of Blacks with poor follow-up was 62% versus 32% among whites. The calculated odds ratio was 7.16 among Blacks and 4.77 among Latino patients. But when I asked one of the authors of this paper about the makeup of the physicians who were taking care of these patients, did they reflect the community they served? And they stated that that was not the case. So I wondered if there was an issue with discordance, patients versus provider, if that makes a difference. Next slide. So there is strong evidence that communication and racially discordant medical interactions is usually less productive and positive in content and tone than in racially concordant interactions. Studies have shown a less positive affect when there are discordant pairs. Studies have shown less relationship building, have shown less health information exchange when there are discordant pairs, and have shown less treatment planning when the physician and the patients are of different backgrounds. Next slide. So the final point I'd like to reference this editorial, Improving Racial Diversity in Ophthalmology Workforce, a call for action for leaders in ophthalmology. Next slide. And some of the points that were made in this article include that leaders in ophthalmology must advance into a state of conscious competence to eradicate injustice and disparities in health outcomes. That greater research support for projects that aim to eliminate racial and ethnic disparities. That there should be they encourage discussions about racism. They also encourage involving more underrepresented minority faculty in the medical school and residency application selection process. And also recognizing diversity efforts in the promotion pathway for faculty. Next slide. The American Glaucoma Society Patient Care Committee and AGS Research Committee are working together to spearhead several research projects tapping into big data to better quantify disparities and inequities in glaucoma care and outcomes among racial and ethnic minorities and socioeconomically disadvantaged patients. Next slide. Next slide. So I do have some concern. Next slide. So this magazine went out to, I think, all ophthalmologists in the United States recently. This is a US News World report stating the best hospitals in the country. And at the front page of the magazine was this highlight of the Wills Eye Hospital, world-renowned eye hospital in Philadelphia. They say that growth, innovation, leadership, we welcome a new generation to Wills Eye Hospital, and these are the new faculty members at Wills. When I looked at this cover, I did not see one Black face. And as you know, Philadelphia is a city of about 50% African-American people. So again, talking about the racial discordance among patients versus their providers, that needs to be considered. Next slide. But I have hope. Next slide. I had the occasion in my operating room a few months ago to look around and find that all of my trainees were Black. So for the first time in my 26 years at Duke, I had a team that was comprised of just of, in this case, African-American men, 2 medical students, a resident, a fellow, and myself. So I do have hope for the future. But as the title stated, inequity and glaucoma indeed cost sight. Hopefully we will have the vision to correct these imbalances. Thank you for your attention.
Thank you so much, Leon. That was a remarkable talk, and you took us over a large and rough terrain, ranging from societal issues to medical system to variations in testing and follow-up, and the extremely important work with adherence and who's providing care. So we greatly appreciate your bringing these ideas to us all, and we look forward to being able to have further conversation during the panel period. So thank you very much.
You're welcome.
Next, it's my pleasure to introduce the moderator of the panel, Dr. David Friedman. Dr. Friedman is the Alfred and Diane Caneb Professor of Ophthalmology. Here he is at Massachusetts Eye and Ear. He's also Director of the Glaucoma Division and Director for Clinical Research at Mass Eye and Ear. Up until May of 2019, this busy guy was the Alfred Summer Professor of Ophthalmology at the Wilmer Institute at Hopkins, very active also with multiple appointments at the School of Public Health. I do want to note that in addition to his extensive research in especially angle closure glaucoma, Dr. Friedman does a wide variety of public health epidemiology and program intervention work. Some of this is with NGO members of the International Agency for the Prevention of Blindness, historically with the Helen Keller International, and currently with Orbis. So I'm delighted to welcome Dave, who will in turn introduce our panelists, and we'll be able to have a conversation to round out the hour. Thanks so much.
Thank you, Suzanne. I do want to thank Leon for quite an impressive presentation. It spanned a lot of issues, and I think we'll have a great discussion. I also want to just reflect for a moment how challenging this year has been for myself in terms of thinking about the way in which I was educated about our history and our society and the truth and reality of how we treat our underrepresented minorities in the United States. Steve, before we started this, who you'll hear in a minute, was talking about how educational equity would greatly alleviate some of these issues. There's so many ways in which equity needs to be expanded across our society, and I thank Leon for at least pointing to some of those, and I look forward to a deeper discussion. But there is really a growing literature, movies, all kinds of things that can help enlighten all of us about what's gone on in the United States for the last several hundred years. And it's not pretty, let's put it that way. I'd like to introduce our panelists. We're very fortunate today to have 3 very distinguished individuals. I'll first introduce Ruth Shoghi, who's an assistant professor at Salus University. She has an MPH in social and behavioral sciences. She's chair of the Diversity and Cultural Competency Committee of the Association of Schools and Colleges of Optometry. And I think what we'll do is we'll have each of the panelists give a reflection and then go on to the next. So I'll leave it to Ruth right now.
Thanks, David, for the introduction, and thanks, Leon, for your presentation. always insightful to really be reminded, and for some of us to hear for the first time what it is exactly we're dealing with when we're talking about disparities in healthcare. And specifically, we're talking about disparities in glaucoma. And for me, I think what stood out in your presentation was really talking about concordance. And it's something that's not often highlighted in research. And there's enough social science research that tells us when there is racial, ethnic, or linguistic concordance, the people that we're taking care of do better in terms of health adherence, as well as their healthcare outcomes. So I think it's important to remember those factors. And I live in Philadelphia, so when you say, we're in a city that, the vast majority of the patients that I see aren't Black, part of their success, is my clinical experience also. But I think they've also built trust in me because we have some shared reference. So I find that very important and something to remember. And then, when you showed your a message from our sponsor slides, how, specifically on the printout, it says this information, this data is really for Caucasian eyes. And so that's just reminding us that the research needs to be much more diverse and robust, because then how do we know we're actually taking care of people appropriately? So those were the two highlights for me from your presentation.
Yeah, that stood out to me as so obviously wrong. You just can't believe it when you read it. Thank you so much, Ruth. I'm now going to introduce Nancy Lin, who is a Senior Vice President for Strategic Partnerships at Bright Focus Foundation. Bright Focus is a great supporter of glaucoma research. Their programs have awarded over $40 million since 1978, specifically focused on the potential to prevent and treat glaucoma. Thank you for joining us today, Nancy.
Thank you so much, David. And I want to thank the IAPB for inviting me and for doing this webinar focused on equity. And I really want to thank Leon, whom I only met this year, because I think in preparing for this webinar and a couple of other things we've done together, I feel like I have learned so much. And I think this year, as David, you point out, was very eye-opening for a lot of us since the concurrence of the George Floyd death, murder, and COVID, and what I've been learning in health disparities. So Bright Focus is primarily a research funder, but we also focus on patient education and patient advocacy. And so I think it was really interesting, Ruth, that you picked up on the concordance and discordant, because of everything that Leon said. Those were the two words I wrote down on my little sheet of notes here, because in terms of outreach to patients and patient education and awareness and healthcare professional awareness and education, we've come to the conclusion that in order to get underrepresented minorities of all kinds to participate in clinical research, so that it's not Caucasian eyes only, that there need to be very extensive outreach efforts into underrepresented communities that are led by concordant representatives of those communities. And that those, and so actually we fund Alzheimer's disease, glaucoma, and macular degeneration. And so we are actually starting this in Alzheimer's disease, where there are tremendous disparities across the boards, Black, Hispanic, but also women who are 2/3 of caregivers, and the age inequity, the value of an older age. We've decided to launch a virtual outreach series, working with local community leaders all over the country, and producing content to give information about disease, treatment options, local resources, to give information first for free with concordant representatives. And and then ultimately to be presenting information about clinical research opportunities that are available. So we're really focused on this idea of avoiding the helicopter researcher going, dropping in on a church or a hair salon and saying, come on, we need you to make our research equitable and representative, but to really give something of value, create that bond of trust that Ruth mentioned. And the last thing I'll say is that I've had the great fortune to work on some movies related to neurodegenerative disease. Glenn Campbell, I'll Be Me, which followed Glenn Campbell's journey with Alzheimer's. And then that went on CNN in 2015. And the first night it was on, got almost 6 million viewers. I think the use of entertainment and media should really be amplified for vision disparities. I think movies, if you think about it, like Henrietta Lacks, and books, or Just Mercy, if we could do more of this about research and vision, this is another area we're very interested in pursuing. Thank you again. Thanks, Leon, and thanks for having me.
Thank you, Nancy. Those are great thoughts, especially, we have had Kirby Puckett, a baseball player with glaucoma. It would be great to have more people stand up. Bono has it and doesn't talk about it either. I'm going to move on to our third panel member. Steve Arshinoff is the 2020 Outstanding Humanitarian Awardee by the AAO for his tremendous work in reaching out to Northern Ontario remote patients. He's an associate professor at the University of Toronto, also a very excellent cataract surgeon and well known in that area as well. Steve's going to comment and discuss a little bit about his program. Thank you, Steve.
Well, thank you, David. So let me share my screen, and let me say first that Leon's talk was really fantastic. Leon was a guest of ours when I was president of the Toronto Ophthalmology Society, and he gave a fantastic talk on glaucoma. So Leon doesn't just talk about equities, but he's a fantastic glaucoma doctor, and we all really enjoyed having him come and speak to us.
Thank you.
So the Canadian Ophthalmology Society asked me if I would join in this webinar and speak about a bit about how Canada is different. Now I put in here the award I just got from the Americans to let you know that I have no intention of criticizing Americans. The vast majority of my research career and work has been due to opportunities provided me by the Americans. And so Canada does some things well and America does some things well. And I'll tell you about some of the things that we do well that hopefully might be helpful to you. And I've been involved in this program, which you can see the pretty picture of the IVAN and the icon and stuff. I've been involved since I was a first-year resident because I was the only one who was arrogant enough to go up to the very far north with nobody helping me and think I could take care of people. And so it's been over 40 years, and I've been running it for about 25 years. And you can see this picture over here when we were welcomed in April of 2019 to Cochrane. Cochrane is as far as you can go north by road before going into the waters of James Bay. And so we treat people in Canada, and our problems are not so much racial issues, but just living in places that are really hard to get to. So I'll tell you a bit about this and about some ideas I had about maybe how some of the things we do could be helpful for Americans. So the first question I'm always asked is, why do I bother doing anything in Canada? Because Canada looks like it's a pretty affluent country and we shouldn't be so badly off. And we're actually a very small part of the world and like we're doing pretty well. So here's a nice picture of Canada. Here's Ontario where I live. And it looks like we're in the middle and it should be like pretty nice and pretty warm, not such a bad place. So let me show you this line. This line is the line above which Canada is remote. Most of you, when you see the weather forecast, you see the winds coming down from the Arctic and coming across here. The coldest part of Canada is the north shore of Lake Superior, not the Arctic. You get -70 just at this red line in Ontario. So most of Canada, over 90% of our land is remote, and getting to those places to take care of patients is very difficult. And like in the United States, most doctors in Canada live in the big cities, but we only have one really big city, Toronto. Montreal is half the size of that, and Vancouver is half the size of Montreal. So about a third of our doctors live near Toronto. Well, it doesn't really help you very much if you happen to live in Northern Ontario. So we always thought that we could assess the problems we face more easily here than going to Uganda or somewhere. But we have problems that are part of our history and politics. And one of our problems is that a lot of the patients we want to care for up in the far north are natives, but they come under federal jurisdiction. But healthcare is under provincial jurisdiction. So we can go see the patients, but we can't take care of them. So we can't really bring our Ontario healthcare system to those patients. And so we first had a huge struggle to get them together to work to let us do that. So we also thought that it'd be easier to get to these places. It turns out that it's harder to get to most of these places than it is to most other places in the world because they're very remote and very cold and not a very good climate. And we thought there were fewer languages, but they speak not just French or English, but Ojibwe, Cree, Nuktitut, and most languages that ophthalmologists don't speak. So one thing, there are some things that help us. Ontario is a unique place because being this remote place, what happens is that was the last place in Canada across which we build a railway or a road because it's the most difficult climate to deal with. And so every year we have this IVAN, which I showed you in the first slide, and we travel this figure-of-8 road. We have this beautiful figure-of-8 road, which goes to all of the most remote places. And that's as far north as you can go by road is where these roads are that I show you. And so we travel 6,000 miles every summer and we take care of all these patients. So how does that help us? Well, one of the things is we have a large remote contiguous area, so we can just drive there. We have funding by the government. So every patient we see, we can actually charge the government and they pay us somewhat to help run our program. We have the CNIB, who's our partner, and they have a foothold or a footprint in every little town in Canada, so they can help us. And the government supports the local hospitals to put things like a plug so we can plug in our truck and you have it work. Every hospital in the far north has a database consisting of every single person within 100 miles and their whole life story. And the Ontario Medical Association has access to all the doctors so we can know who we contact when we go up there. So here's an idea where we go, and this is one of the native places we go to. And we go and we talk to the natives and we bring them diabetic education because a lot of them are diabetic. But if you look at this map, you'll see that there are a lot of native reserves that even our roads don't go to. And that's one of our big problems. And we try to get them and to educate them, but it's still one of the outstanding problems that Canada has. So what's our healthcare system like and how is it better or different than yours? Well, we try to provide equity in healthcare and we don't really have any racial intolerance in our cities very much. We have more access problems because of where you live. And I live in Toronto, which is the most cosmopolitan city in the world. And my practice is probably more diverse than any of you. I see 30% white, Anglo-Saxon, European, Italian, whatever heritage. 20% of my patients are Caribbean Blacks and 10% are African Blacks. Not many are American Blacks, not many live here. We have 20% Chinese or from Hong Kong or Vietnam and 20% East Indian in my practice. So every day I see people from multiple jurisdictions and I really can't be prejudiced because they're all different and not like me. So they're all fine and I really enjoy them. They tell me about going to different countries and what it's like. My staff are also diverse, but the problem I have with them is it's hard for me to hire someone, let's say from Bangladesh, when the Bangladeshi population has only been here for a few years. I have to wait and give them 20 years to educate their children. But the indigenous patients are the ones who are the outliers. So our success seems to be that we're aided by having a healthcare system that treats everyone well and offers it to everybody. We have large, diverse immigration, so no one's really prejudiced because you're prejudiced against yourself then. And we have a residual problem of getting education to where we have people living in remote communities. I did read this book about Henrietta Lacks, and when I read that book, what struck me was we had this group from Johns Hopkins, probably the most educated people in the United States, and literally 50 miles across from them, across the Mason-Dixon line, we have this incredibly uneducated people who came from slavery and were not given an opportunity to get education. And they complained about the healthcare they received and the system not taking care of them well. And I think both sides were right. And I think the problem that you have is similar to our problem. Our problem is educating our natives in the remote north. And your problem is educating the people who came from slavery and giving them opportunities to earn a reasonable income and get educated. This is not anyone's fault that's currently alive. It's a problem you've inherited. And I respect you for trying to address it. And I think it's a challenge. And I offer my help or advice if I can give any, but I encourage you to keep doing it and to educate your population so they can take part in healthcare and everything else. Thank you very much. Those are my thoughts. Hopefully it's a bit helpful.
Thank you very much, Steve. It was great to have you give us that walkthrough. I remember the first time I saw that and was so impressed with the outreach and efforts. It does point to some of the issues raised by Leon. Some of it is access and ability to get care. You pointed to the reduced care provided within Medicaid and even more so within the African-American community in the Medicaid population. What do you think could help with that, Leon? Do you have some thoughts? And we could go to all the panelists being up, I think, at the moment. That would be fine. What would be your thoughts about ways to improve that?
Well, I think Steve hit the nail on the head. I think it's the education piece, education for providers, education for patients. When I reviewed a lot of this data for the first time, it was educational for me. And so I think the more we can do to get this data out there, finally we'll get some movement, some traction to find better ways to take care of the whole community.
Yeah, for me, it all comes down to a whole nother piece of this outside the patient getting better educated so they can be a better advocate for themselves is learning how to be empathetic in some way, learning how to sit in the other person's shoes that's across the room from you. And it's interesting about the concordance and discordance because there's no question we have a natural affinity for people just like us. You know, somebody reminds me of my grandma is maybe going to touch a piece of me that somebody who doesn't remind me of anybody in my family touches. But we have to figure out ways not to fail all of our patients, you know, and that concordance thing really points to some underlying, I think, human nature. Actually, for me, I think it is, and I think it's one of the best arguments for having more diverse populations treating patients because it will help, and also just for this empathy thing I was talking about. Ruth, any thoughts on how that affects your guys' practice and things that you do within your team to improve communication and other aspects of care?
Yeah, I think, as everyone has said, education is a big part of it, educating ourselves, as well as adequately educating our patients. And the thing is, when we look at information with all things being equal, when, education level of education is equal, socioeconomic status is equal, there are still disparities in this healthcare. So now there's been more conversation most recently. It's not new conversation, but I think we're revisiting these conversations about talking about implicit bias and getting at the things that are still allowing these disparities to be so prevalent. So I think, looking at that, and perhaps that's the empathy piece that you were touching on, David, of, how do I figure out on an individual one-on-one basis, how do I better take care of the person sitting right in front of me? But then on the larger scale in the community as a whole that I'm working in, so now we're talking more about public health, how do I better take care of that community as a whole? And sometimes that requires having, people as part of your practice who have some concordance, if you yourself don't, with the community that you're taking care of, and making sure that leaders in that community are part of your strategic planning on how to best, to get your outreach going and who to talk to and things of that nature, because it's a community effort as well. So I think between that and understanding our biases that allow this to persist is going to be important.
So Leon, how do you get more people into ophthalmology and optometry from the minority groups? I mean, the pipeline that you just showed was just devastatingly terrible. 2%, 2.5% of residents. I mean, it's not like that's going to be fixed tomorrow. So what do we do? Because it's obviously not appealing at this point.
Well, there are national organizations that are trying to address that, Dave. You may know that the Academy has the MOM program, a Minority Ophthalmology Mentoring Program, that's been very successful in its short existence. Probably instrumental to getting some of those folks in the picture with me in my OR. And also the NMA has a RAB Venable program that's been successful for 20 years with getting more underrepresented minorities into the training programs. So it's really just a start, but we got to start somewhere. But I think that these programs will continue to create traction and ultimately lead to more representation.
Suzanne, do you have any thoughts about the talk so far, or questions that you want to ask, or any from the audience that you think are wonderful?
Well, we do have a number of questions coming in from folks, and I know we just recently were talking about the technology and the concerns we have that a lot of the tech has been tested and developed on only one part of a population. And one question we have is how we can work together to ensure that technology not only is relevant in its grading for all populations, but also that equipment and services are available to everyone who needs them.
Yeah, so I think that's a great question. I think that there's an obvious failing on so many levels that the FDA would allow such a device to be approved without having normative data for the many populations in which it's going to be used seems wrong. The fact that it still exists and the company hasn't figured that one out to get another normative database. There are easier ways now to get to these data. So there's lots and lots of images that have been collected by lots and lots of groups over long periods of time. And with machine learning and other techniques, you can get normative data quite easily. The question will be, how do you get them in the machine so that we can use them day to day? Because they exist right now. And I think this is a good call for implementing that. I think we should be moving over to that. One of my colleagues here has a website where you can send your data and it'll change the normative data based on certain parameters. I'm not sure if ethnicity is in there, but it certainly should be considered as one of them. Another question. Yeah, go ahead. I'm sorry, Steve.
I don't think it's fair for the FDA to restrict sales of a device because the device came from Europe. But I think the FDA can demand that these companies do post-market studies
Sure,
on
exactly.
American population and different groups.
Yeah,
I also want to talk about the mention of empathy. You know, I don't have any trouble being empathetic to my patients. As you saw, my patients are mostly not like me. They're from all over the place. And I just talk to them. And it's actually quite interesting because, you know, I had this lady with terrible glaucoma from Nigeria. So I asked her about Nigeria. And in between crying about her eyes and whatever, she told me about Nigeria, where she came from and her family. It was very interesting. And I do that with all my patients. And I try very hard when I see, let's say I see teenagers sometimes, and they come from families that I'm caring for some other reason. And sometimes you see a kid and you recognize this kid is like exceptionally bright. And I say, well, what do you plan to do with your life? And a lot of them want to be like a nurse or something like that. And I say, why don't you go into medicine? And then the mother sitting beside them says, well, yes, so-and-so gets 95 in school. I've told her she should aim higher, but we have no family history of anyone getting an MD. So I said, look, it's not hard, just stay in school. And I think if we encourage them and show that they are part of our society, they'll do well. And I have a number of my patients that are doing well because they keep going on and doing things. And I think it's very common across Canada because we have a different view of things. And we have lots and lots of people from different nationalities and backgrounds.
Yeah, there's no question, Steve, that we can learn from Canada.
Well, I think
you guys didn't have slavery,
right?
and all the all the stuff that we still are trying to deal with. Leon, I'll give you some of the last word. We have 2 or 3 minutes. If you were right now to try to improve the care of, let's just focus on African Americans with glaucoma, knowing that we have systemic racism and tremendous problems in our society, what are 2 or 3 things you try to do like right now in terms of making that better?
Well, I'll go back to my first slide when I highlighted Congressman John Lewis. He was instrumental in getting the glaucoma screening bill through Congress, and that program has since been deleted. So first thing I think I would like to try to re-implement that to increase glaucoma screening throughout the country for high-risk groups. So I think that's really important. And a silent disease like glaucoma, as you know.
And we can do it much better now too. We have the tools to
absolutely
do it.
Absolutely. And the education piece, I'll keep coming back to the education piece. A lot of young folks in college and high school may not think they have what it takes to become an ophthalmologist, but I think we need to get into those young environments early to show them that they also can achieve things that we've achieved.
Well, I'll give the last word to Suzanne, who started us out. Suzanne?
Thanks so much, Dave. And thank you everyone here on the screen for participating. I'll do the wrap up right now. This was a very stimulating hour. I want to thank Dr. Herndon, Friedman, Dr. Shoghi, Dr. Arshinoff, and also Nancy Lynn for just bringing all this wisdom, experience, and concern to the table for this conversation. I'd also like to thank the IAPB events team and the many of you joining in now as participants, and those of you who will be enjoying the recording later. So once again, on behalf of IAPB, I thank you for participating in the North America region Glaucoma Week celebration. Thank you. Thank you all.